Good morning, everyone. Welcome to day 3 of the 30th Annual Global Diabetes Convention, JPEF 2025, here at the Nilla Hall. It has been an incredible journey so far, and today promised to be just as impactful with the sessions that span the aging spectrum, innovations in kidney care, nutrition strategies, and metabolic health. We are all set for the day of the insight exchanges and progress. To chair this opening session, I warmly welcome Dr. Jayakumar C, Head of the Department, Professor of Medicine, Sri Kogulam Medical College, Trivandrum, and Dr. Yaseen Unes, Diabetologist, Jyotidev's Diabetes Center, Haripad. Sir, kindly take the stage.
A very good morning to you all. You all know this is the third day, and it's a morning session. People are only arriving. And first of all, let me thank the JPEF Foundation for inviting me to chair this session. We have two interesting talks today. The first is by regarding sarcopenia and insulin sensitivity and metabolism with aging, a complex subject which will be dealt by none other than Dr. Vinod Mittal. He is a senior consultant diabetologist from Delhi, director of so many institutions. He has been the past chairman of RSDA. He has vast clinical experience, lot of publications. Let us hear directly. You all know the topic is a very complex one. Both sarcopenia and insulin resistance are interrelated. So let us unravel the mystery by Dr. Mittal. Please, sir, carry on.
Dear Chairman, for those kind words. It's my proud privilege to be here to share my knowledge on sarcopenia, insulin sensitivity, and metabolism with aging. We all know that sarcopenia is very common, and as we grow old, there is almost 3% of muscle loss every year after the age of 50. Sorry. Now, how we define sarcopenia, it is not only the muscle mass, it is the muscle strength and function also. So mass, strength, and function, all three combined is sarcopenia. And as I told you, 3% every year after the age of 50. And more than 60 years, it's there in almost 10 to 15%, maybe more population. This is underestimated. And the rate and severity of this sarcopenia would depend on the health status, our activity level, our food intake, means the protein intake, and resistance training exercises. Exact mechanism is not known, but as we grow old, we become less active, we take less food, and as a normal process, there is more accumulation of fat and less, because muscle, we are not very active, so we are losing muscles. So there's a loss of muscle as well as there's accumulation of the fat. Now, other important thing is the world population is aging. So what is happening that, we are having this more, just a moment. So aging population, and Korea is the leading country, even Japan followed by Korea. So this aging itself leading to more prevalence and incidence of sarcopenia, because we were not aware, now we are becoming aware because people are aging more. And it leads to not only physical limitation but also poor quality of life and then health care expenditures. Now we define this old age as, now this is again something very important, that 60 to 74 is young old, 75 to 84 is old, and oldest old is more than 85. That's how we have started defining old age now. So whenever there is a sarcopenia, there's more history of more fall, more fractures, more hospitalization, more premature death. And generally it is asymptomatic initially, unrecognized, so early detection and prevention is the only, answer to this problem. Now, what we have to do is early screening. The DEXA scan is very important, and then BIA, bioelectric impedance, CT, MRI, and other. Plus symptoms. Symptoms are suggestive of like falls, weakness, slow walking. The speed becomes slow, and there is problem in climbing stairs or climbing down up or climbing down the stairs. So that's how we screen. The most important, if we see here, is two things are there. One is we measure the gait speed. So if gait speed is less than 0.8 meter per second, this is first pointer towards sarcopenia, and the second is sarcopenia defined by BIA, bioelectric impedance. There we can see if in man, if it is, it is a muscle mass less than 8.5 kg per meter square, and in ladies 5.75 kg per meter square, or we can even go for DEXA scan. Now, what are the causes of aging is the most important as we grow old, obviously. There is, and this is due to basically, decreased physical activity, anorexia. Neuronal units also go down, decrease blood supply to muscles, and even small for birth weight babies also leads to sarcopenia and increased inflammatory cytokines. Now, overall, there is resting energy goes down, insulin sensitivity goes down. This is very, very important. As we grow old, we know there is possibility of diabetes. Why? Because muscles are decreasing, and muscles are there to for the uptake of glucose. So when GLUT4 receptors go down, there would be less uptake and definitely more chances of diabetes. And at the same time, there is also accumulation of intra-abdominal fat leading to more inflammatory cytokines and directly responsible for cardiovascular disease. So sarcopenia along with abdominal obesity is very, very dangerous. So just sarcopenia may not be that dangerous. People are still, very thin, not having, still they are, doing the routine work. But people who are having central obesity with sarcopenia is becoming very, very dangerous. So there is basically a vicious cycle, aging, we cannot stop, obesity and sarcopenia. So this can be curtailed to some extent by, endurance as well as resistance training exercises and increased quantity of good quality proteins. Then only we can address these. Otherwise, there is a vicious cycle, aging, sarcopenia, obesity, and that becomes very dangerous in old age. Now, overall, if we see this, basically aging, skeletal muscles are going down as far as the mass, strength is also goes down and function. And adipose tissue becomes more inflamed. The size of fat cell increases, and that causes basically, release of inflammatory cytokines, and this leads to sarcopenic obesity. So sarcopenia is not that dangerous, as dangerous is as sarcopenic obesity, because obesity leads to more inflammatory cytokines, insulin resistance, and other cardiovascular and metabolic syndrome features. Now, here again we can see that if fat mass is high, just fat mass, it is sarcopenic obesity when muscle mass is less, okay? So this is otherwise, if just fat mass is less, there's only sarcopenia. It is not very dangerous. But if fat mass also goes up, then it is very, very dangerous, and it is sarcopenic obesity, which is most oftenly, seen. Now, these are other important things, for diagnosis for Asians: functional, physical function, muscle strength, and muscle mass. As I mentioned, it is not just the mass of the muscle, it is function, strength, and mass, all three. So gait speed, I mentioned, less than 0.8 meter per second. It is a pointer towards sarcopenia. Muscle strength, again, by hand grip, dynamometer, we can do it. It is, can be kept in the clinic also. Men, it is less than 26 kg, and for DEXA, muscle mass can be found out. So all three are important, and to diagnose. This is our own, not Indian, but European. This is, like revised European. I'll be showing for the Asians also. So here, hand grip, dynamometry and appendicular skeletal muscle mass. So almost same, features are there. This is, for South Asian working group, and this is basically, South Asian for on sarcopenia. So muscle strength done by hand grip. Lower limb muscle strength can also be checked. Then muscle function, as I told you, the speed and sit to stand and chair stand test. And then, muscle mass by anthropometry, which we do normally, in our day-to-day routine. And then with the help of DEXA scan as well as bioelectric impedance. These are other working groups. So I won't be going to detail European working group and international working group on sarcopenia. So different definitions are there. But I've told you for the Asians, which we should follow. So cutoff points also, vary depending on different, associations. But for Asian, as I mentioned, this is for Asian working group. Gait speed less than 0.8, hand grip less than 26. And then, appendicular mass, male less than 7 kg per meter square. Now, this is very important slide. This you must focus on. So, aging, obesity and physical activity. Now, with aging, there is decrease in muscle mass. These are all, the parameters. Strength. Insulin sensitivity also goes down as the muscle mass goes down, mitochondrial capacity goes down, the content also goes down, and regenerative capacity with aging. This all, are impaired. Obesity, again, everything is going down. So we can't prevent this, but we can prevent obesity. Now, with physical activity, we can see there is increase in the muscle mass, increased muscle strength as well as function, improvement in insulin sensitivity, improvement in mitochondrial function. So basically, continuation of exercise in the form of endurance and resistance training is very, very important as we grow old. Now, metabolism, again, muscles also secrete myokines, which have autocrine, paracrine, and endocrine effects, and these have effect on bone, pancreas, liver, and adipose tissue. So, as we grow old, there is a decline in insulin sensitivity, there's more possibility of diabetes, and, so exercise training becomes very, very important. Now, body composition, again, there is, as we grow old, there is imbalance between energy expenditure and intake, and accumulation of intra-abdominal fat. Even intramyocellular, fat, lipid accumulation in between the myofibrils, that is also important. Can be done with even ultrasound, we can find out. GLUT4 receptors go down. And then muscle fiber, this is again very important. There's decrease in the fast twitch, and there is little increase, but overall decrease in one also, the quality of one also. So type 2 fibers, there's decrease followed by type 1, okay? So this can be explained better here, that long distance is late, the type 2 comes first. So the running, the fast movement, so you would know that when we grow old, our speed becomes slow, our running becomes slow, but we can still do long distance. But as we grow further old, even the long distance also, is impaired. Now, molecular changes are also there, in the terms of changes in myokines and intracellular fat. Management approach is we have to find, screen, assess, confirm, and find out the severity. As far as, agents are concerned, transdermal testosterone and selective androgen receptor modulators, they all, can be given. As far as anti-diabetic agents are concerned, they all basically, except metformin has shown some small increase in muscle mass and pioglitazone. Otherwise, take my words, we always talk of weight loss, weight loss, weight loss. I think we should change this term to weight management. Means fat mass loss with preservation of muscle mass. We just say loss of weight. And one more important thing is whether it's GLP-1 or any agent which decreases weight will decrease both fat and muscle. And in elderly, the muscle mass decrease is more important than the fat reduction, because already there is a less of muscle mass. And it going down further, GLUT4, so there is increase in diabetes and other, parameters. So muscle mass decrease in elderly. So when we are giving GLP-1 or SGLT2 in elderly people, I'm not saying they're contraindicated, because cardio-renal protection is equally important, more important. But at the same time, we have to see that their normal daily routine function should not be impaired. If it leads to muscle mass, we have to stop these agents significantly. This is one point we have to understand. Now, other is then a combination of exercise and protein. Whey protein is the best protein. Whey isolate is also available. Whey concentrate is also available in the market. And I won't be going into detail, but the best sources would be lean meat, poultry, seafood, and dairy. I'll just take 1 minute more. Then plant sources, beans, lentils. So these naturally occurring, food is more important than all these, they can be given in certain circumstances. Then creatine phosphate is also, some people may need to take it because this is a rapid energy, buffer. Then even selenium supplements have shown some importance in increasing muscle mass. Magnesium supplements are also, given in some patients, and the trials have shown of these proteins and other different diets. Now, as I mentioned, resistance training is the most important besides endurance. Now, this slide it shows that intensity. This was, it was just, I think, a couple of months back only it was published. Intensity of exercise is more important than the quantity or volume of exercise. Suppose you do for half an hour. So intensity, the peaking, that is more important than the length of duration of exercise. So this point also has to be understood for longevity of life. So that's what. So I would just straight away come to my last slide. So basically aging is, we're becoming more and more, aging is rapidly growing. 30% of overall population, aging population may have sarcopenia. Early recognition, timely intervention is most important. Lean mass loss is significant, more significant in elderly people than fat loss. They may not be gaining that much by losing fat, but they would be losing more by losing lean, the muscle mass. So the final answer is endurance resistance training exercises, good nutrition, and some medications if required. As I told you, magnesium, selenium, creatine, phosphate, good quality proteins. Thank you for your kind listening.
Thank you, sir. Thank you, sir, for your very lucid and concise presentation of a complex subject. And there is one more talk. We'll take the questions and discussions after that. Thank you, sir.